I'm going to tell you now a brief story that was very important for my coming to palliative care. As Tony has mentioned, I've been working from the beginning of my career in neurology. I'm a neurologist in motor neuron disease, or as it is called outside the UK and Ireland, amyotrophic lateral sclerosis, a name that is as horrible as the disease is. Back in the 80s, I met this patient, Mr. M, who was a very successful businessman, quite wealthy, and he contracted motor neuron disease, or ALS, as we call it, at the age of 48, which is young but not too unusual. And within 3 years, he was tetraplegic, he was fully paralyzed, he was bedridden, and he came to our ALS clinic. And he could still speak quite well. And what struck us immediately was that he had a total serenity of spirit, and that he obviously was trying to make everybody feel at ease, and we thought that was our job. But that's actually what he was obviously doing. We were at the beginning of creating our ALS clinic, so we were very concerned that somebody in this situation should probably be desperate, if not suicidal, but that wasn't the case. And he told us his story that, yes, at the beginning of this disease, he had had suicidal thought, he had felt desperate, and then a friend had told him that he should consider meditation as a way of coping with this. That was a fairly new thing in Germany in the 80s, and he had done so, and that had completely changed his quality of life. And he told us that he felt his quality of life now was better than before he had the disease. That came as quite a shock to us, because we were raised in a medical ethos that was based on doing and curing and healing and getting rid of diseases. And somebody showing up with ALS and telling us that his quality of life was better with the disease than without the disease completely challenged our way of thinking. And the first and easiest reaction to something like that was to declare his attitude as pathological. In fact, that's what several of my colleagues did, and said, well, you should refer him to the psychiatrist, because there's obviously something wrong with this guy. How can he possibly be happier with ALS than without, and facing death to boot? The point is that he had no sign whatsoever of a mental illness. He was perfectly at ease, and he was trying to make everybody else at ease. And in fact, he helped a lot of patients on their way. He was one of the first patients to receive non-invasive ventilation in ALS, and helped other people through their fears with it. And he had absolutely no fear of dying. He required almost no medication, and he died very peacefully in a hospice. And during that period, he influenced many nurses and physicians. And so this was this first encounter with Mr. M. really shaped my way of thinking and brought up a change in paradigm for our group. Because we suddenly realized that what we were taught is that we as physicians are there to take care of the poor, sick, and dying patients that desperately need our help. And we found out that it can actually be the other way around. That there are many situations, or there can be situations at least, in which an incredibly ill patient, by all medical standards, can actually be a teacher for us as physicians and nurses and other healthcare professionals. So we found out with the help of Mr. M, that spiritual care is actually a two-way process. And that really started us thinking. So we started thinking, and in our group we said, well, this is weird, and we're getting too involved with all this touchy-feely stuff here. So we really need to do some serious science here and try to demonstrate that this is actually all irrelevant. And so we started to do some studies looking at spiritual care and related fields. Now, we had to ask a real spiritual care teacher for help, and so we asked Christine Longacre. And Maria did a seminal study looking at Christine's 3.5-day training in spiritual care. It was done in Munich for healthcare professionals, and we looked at several outcomes before, after, and 6 months after the training. And we looked at attitudes towards work, we looked at the self-transcendence scale, we looked at spiritual well-being, and we also looked at the Idler Index of Religiosity, which measures more formal religiosity. Now, many of you know Christine's training. It's based on the Tibetan Buddhist tradition, but it's non-denominational. It's mostly focused on the reflection of one's own fear of death, rather than teaching methods on how to deal with somebody else's spiritual problems. Techniques of active listening, dealing with unfinished business, contemplation, and meditation. And here are the results. The index of religiosity did not change at all. But even 6 months later, you could find on a group level, which is statistically quite a strong affirmation, on a group level, you could find sustained improvements in spiritual well-being, self-perceived compassion for the dying, compassion for oneself, attitude towards one's family, satisfaction with work, reduction in work-related stress. So we actually have a burnout prophylaxis here, evidence-based burnout prophylaxis, and attitude towards colleagues. So this is for the, there might be some managers here. This kind of thing can save you money. You know, this is a powerful argument. And so in conclusion, and these are things that have been said over and over again, but not by everybody, spiritual care is for the patients, for the relatives, and for the team members. And as has been said several times, spiritual care starts with ourselves, and it starts here and now, because as Belmont always says, healing happens in the present moment. Thank you very much.